Thanks again, everyone. My pleasure, Kypros. Thank you for having me today. Again, happy Independence Day from the United States to everyone. Everybody's barbecuing today and partying, and we're partying away all over the world today. Thanks, Kypros, for allowing us. So no conflict of interest, lots of research, and the aim, again, is to have a healthy mom and a healthy baby, like we were all saying. And Roberto covered beautifully, great two first lectures, covered the fact that, again, both Shortcut and McDonald invented, quote unquote, cerclage for somebody with cervical issues. So I think that one of the main themes here is that short cervix, open cervix, those are the patients that benefit the most from cerclage. And it's amazing that we're in the fourth editions of these guidelines. There are so many randomized trials. We talked about meta-analysis, but there's so many randomized trial now guiding our clinical management for cerclage. So I'll go over indications, timing, and I won't go over technique that much because we don't have time, but I'll be happy to answer questions. One thing I want to make sure people understand, we should use the same nomenclature. Actually, the American Journal of OB/GYN, which again, I congratulate, incredible impact factor. Almost all of those articles, Roberto, use history indicated. We shouldn't use prophylactic elective. They're very confusing. You said it yourself. This 12-week, 14-week-old cerclages are done based on the poor obstetrical history. So let's call them what they are, history indicated. Again, almost all journals use ultrasound indicated when the cervix is short. And I prefer to use them. This has been around for 2005. 90% of publications are like this. If the cervix is open, we should say what it is, physical exam indicated. If we say rescue, salvage, emergence, we get it all confused. So these three, history indicated, ultrasound indicated, and physical exam indicated, much better nomenclature. We covered the fact that history indicated cerclage, there are some trials, the MRCOG, the biggest one, almost 1,300 patients, overall negative, as most other old trial, but then the history of 3 second trimester miscarriages or preterm birth, so the subgroup being significant. This really has limited, as Kypros and Roberto said, clinical importance now, because I think most of these patients can be followed. I actually saw a case, somebody had 4 preterm births, was referred to us, but some were at 34, some at 36 weeks. Those women can be followed with cervical length, and I'll show you the data for that. So at most, if she really has more than 1 second trimester loss, if she really has a history of trauma to her cervix, she has had 2 second trimester, painless, 20-week losses, maybe we would put a history indicated or a 12-week cerclage after a normal NT. Most of the time, we actually follow them. And again, if we do this history indicated cerclage, we do it usually between 12 and 14 weeks after an NT, but we do it very rarely now. So here is the scenario, singleton gestation, multiple second trimester losses, history indicated cerclage. What about if she has another preterm birth baby? In this case, transabdominal cerclage is, we perform a few of these every year. I think that the only really controlled study, which we published years ago in the gray, showed that in women who have a prior history indicated cerclage, which failed, she delivered before 33 weeks. In these women, if you place a transabdominal cerclage into preterm birth, it's less than 20%, and it's about 40% if you do again another even highly placed transvaginal cerclage. So this and the randomized study from England and other data said a transabdominal cerclage does work in a very selected subgroup of women, I'd say those with a prior failed vaginal cerclage. I don't have time to go over the technique, but most of the cerclages, there was a question in the chat, most of the cerclages that we do abdominally, we perform by robotic. This is with Dr. Tifi, one of the doctors here at Jefferson in Philadelphia. And again, I don't have time to go through the whole thing, but basically you dissect, and then eventually you place the stitch. As you can see, at the level of the internal os is much higher place. We use Merceline basically for all our cerclages. There's some evidence for that, and they do really well. Much harder to do in pregnancy. If we do it in pregnancy, it's because they haven't shown up to us for referral before. Otherwise, we do it inter-pregnancy. So again, singleton gestations, about up to 10% of them usually have a prior spontaneous preterm birth. Over 90%, as I said before, we follow with cervical length. And this brings up the issue we discussed before. We start usually at 16 weeks because most of prior preterm birth are only one. They are at 30 weeks, 28 weeks, 36 weeks. So you can start at 16 weeks. Very few people have a short cervix. But we published actually in the White Journal 15 years ago that people do shorten before 16 weeks. And so if somebody's at, let's say, a 22-week preterm birth, you cancel her, she declined a history-indicated cerclage, we actually would say we would favor cervical length screening. We would even start at 12 weeks, 14 weeks, because people can shorten that early and you can place a cerclage for those with a cervix of less than 25 millimeters. Here it's an important meta-analysis published by Daniel McKee and our group, comparing cervical length screening and history-indicated cerclage. So in this group, 100% of the people get cerclage. In this group, only about 40% of the women have a short cervix, and because they have a short cervix, they get a cerclage. So 60% of them, even all of these have a prior preterm birth, 60% of them never shorten, they don't need a cerclage. I am not in favor of cerclage to everyone, of progesterone to everyone. We need to be very selective, and this is a way to be selective, doing cervical length screening, saving most women for cerclage. But if they have a cerclage, if they shorten, their outcome is the same, as you can see here, to women who all get a history-indicated cerclage. So very, very helpful. In general, 40% of women you follow with cervical length screening who have a prior spontaneous preterm birth shorten, and they get an ultrasound-indicated cerclage. They usually do well, but some of them still have a preterm birth. What would you do in those cases? If you compare history-indicated cerclage to cervical length screening in women with a prior ultrasound-indicated cerclage, the overall incidence is the same of preterm birth. But this is important, and this, I'm sure, in your high-risk practices happens. Prior ultrasound-indicated cerclage, she delivered early, less than 32 weeks anyway. If you follow cervical length, again, they always shorten. They always shorten. So in this case, this is a small subgroup of women with a ultrasound-indicated cerclage in the prior pregnancy. She delivers spontaneously early anyway. In the next pregnancy, if they still have the guts to have another pregnancy, we will place a transvaginal, early, very high 12-week history-indicated cerclage. Switching to women with a prior spontaneous preterm birth, we do give progesterone. Again, this can be open to discussion, but we do give progesterone based on the history, and we do cervical length screening, again, mostly 16 weeks, sometimes earlier. And if they shorten, and 40% do, we add cerclage. And I think everybody agreed on that, and certainly AJOG and SMFM, Royal College, ACOG, et cetera, agreed. And Roberto showed this meta-analysis and a 30% decrease in preterm birth, 36% decrease in perinatal morbidity and mortality. So this is really about saving babies, and I'm so proud so many babies are saved. And we finally came to 25 millimeters as the cutoff. Again, the shorter the cervix, and this John Owen showed 10 years ago in the gray, the more efficacious that cerclage is. And all guidelines to cover this around the world agreed. Cerclage, cervical length, short, prior preterm birth, very important, prior preterm birth. There's agreement everywhere. Switching now to maybe the most controversial issue, we do universal cervical length screening, like Kipros does, like Roberto does, like many of you do, I think Alfred, etc., and many of the wonderful people I saw in this amazing webinar. So we do a cervical length at 20 weeks with the anatomy scan. The incidence here of a short cervix is much shorter. It's 1 to 2% here in Philadelphia. depends on your population. It may be a little bit lower in some other countries, a little bit higher in high-risk groups, but in general, they're short. And like we all agreed, vaginal progesterone should be the first line. But by Roberto's own wonderful, great journal meta-analysis, 17% still deliver before 33 weeks. So it was brought up, should cerclage be an issue? And this is the data from the randomized studies. Cerclage in red, controls in black and white. These are randomized trials, so these patients are the same, looking at different cutoffs for cervical length. Cerclage, as you can see here, the column is usually shorter, did not become significant. So some people use this to not recommend cerclage in these women, which I completely understand. But it came over again, this 10 millimeter cutoff. I think this is the first publication where it came around, or one of the ones at least was quoted and cited most. We found a 32% decrease in preterm birth in women with singleton, no prior preterm birth, but a short cervix, in this case, less than 10 millimeters, and it was significant. So based on that, we started a randomized study, which is still ongoing and doing well. And I completely agree. There were a lot of questions on this. We found, like many other data points, many other analysis of level 1 data, that adding indomethacin, this which the tocolytic used most of the time, indomethacin for 48 hours, we use 100 milligram loading and then 50 Q6 for 48 hours around the time of the cerclage, and using 1 dose of antibiotic. We usually use Ancef just before we start the cerclage. In this case, again, ultrasound-indicated cerclage, well proven by randomized study by Dr. Miller in physical exam-indicated cerclage. Antibiotics, I agree with Roberto, and indomethacin do help, especially peri-cerclage, making sure that you're not infected. And as I said, we have an ongoing randomized studies on this population. I mentioned this before. If your cervix is 10, 11 millimeters or less, 30% of the time your cervix is dilated. So please do a physical exam, no matter what the history is. If you're doing transvaginal ultrasound, the cervix is short, very short, less than 11, see if she has prolapsed membranes, making sure you do the right treatment, and eventually you end up with the right outcome. We mentioned physical exam-indicated cerclage. Roberto plea for amniocentesis, which I completely agree. The randomized study showing that cerclage, and again, indomethacin, again, the combination was beneficial, and many other retrospective but controlled data saying that really for an open cervix, if she's not infected, cerclage helps. So I think this has become standard care, certainly in the US, I think in many places around the world. Last point on cerclage, twins. I'll cover twins in general, short cervix and dilated cervix real quick. Really, I think there is no point for putting cerclages in twins. There are many, as you can see here, studies, randomized studies, 2 of them, even if small, many non-randomized studies, and even in triplets, there are data showing that a routine 12-week cerclage is not helpful. What about a short cervix? And again, a lot of this was published somewhat recently. Twins, even if they get a vaginal progesterone, for the 20% of twins who have a short cervix, 25 millimeters or less, as you can see, even if you pick, let's say, 34 weeks, 40% of twins with a short cervix, despite vaginal progesterone, deliver early, and 18% deliver really early. So what about cerclage? The data has been confusing. At first, we reported an increase in preterm birth, which was really scary for cerclage in short cervix in twins. When we analyzed for the characteristics, which I think is really, really important. I think anytime you do meta-analysis, as we said in the first lecture, you really need to look what's in it, what are the patients, make sure that they are similar. There are not that much variations, and when we adjusted for those variables, we found actually the cerclage was not detrimental. Then Dr. Roman Jefferson published in the great journal that while cerclage for 25 millimeters as a cutoff was not significant. Again, the issue of the shorter the cervix, the more cerclage helps. 15 millimeters or less, she actually showed a significant 4-week prolongation and halving of the risk of preterm birth. Really important data. It was shown by other data, including in the Great Journal. As you can see here, there are several studies showing a prolongation of pregnancy with twins with short cervix, especially if the cervix is less than 10 or 15 millimeters. And that's why we're doing a randomized studies. Unfortunately, it's going very slow. You can see here, only 13 patients randomized. We need your help, please. And this is the data for twins and dilated cervix. The last piece of data I will show you before my summary. Here, another report from the Great Journal reporting an even longer prolongation of pregnancy if you do cerclage on a short cervix. And then I think the final 2020 Great Journal publication, again by Dr. Roman from our own place and collaborators from all over the world, not only the US, comparing physical exam indicated cerclage to no cerclage in twins with an open cervix, mostly die twins without a preterm birth, found to be have a short cervix and then a dilated cervix at around 19 to 20 weeks. Again, the cervical dilatation, as you can see here, was on average 2 centimeters. And despite vaginal progesterone, the ones who had cerclage did much better here in terms of prolongation of pregnancy compared to the controls. Basically, if you have twins and an open cervix, you're going to deliver really early, before 22 to 24 weeks. And here's the data shown another way, and I like, to save time, that perinatal mortality was much, much lower in the physical exam indicated cerclage, while in the cerclage ones, most of those babies unfortunately did not make it. So a combination, again, of cerclage, endomethacin, and 1 dose of antibiotics to increase preterm birth, prolong, in this randomized studies, delivered by more than 5 weeks and decrease mortality by 77%. I'm so happy. Amanda was the change she wished to see in the world. So don't do cerclage in all twins. Consider cerclage in women with a short cervix, less than 15 millimeters. We're doing the randomized studies to prove this. I don't think this is final at all, while I think now there's level 1 data that with a dilated cervix in twins, cerclage may be indicated. In terms of tips for cerclage, I think it's important to make sure the baby's doing okay, and you're looking at the cervix by ultrasound before. Most important issue is to place the cerclage as high as possible, to pay attention to the posterior bite, which is the one that slips most of the time. And in few cases, consider transabdominal cerclage, which most of the time we do robotically pre-pregnancy. And I think technique, we don't discuss it enough, makes a big difference. So in summary, in singleton before 24 weeks, you could argue in some cases even later, but the evidence is mostly for before 24 weeks. If they have no prior sperm birth, transvaginal, ultrasound indicated cerclage, if the cervix is short, hopefully the randomized studies will confirm this, yes or no, and shed more light. Definitely standard of care, prior sperm birth, ultrasound indicated cerclage if the cervix is less than or equal to 25, prior spontaneous preterm birth despite a prior ultrasound indicated cerclage in a prior pregnancy, 12-week history indicated cerclage, prior transvaginal indicated cerclage, and still spontaneous preterm birth early transabdominal. And if the cervix is dilated, that's when we do the physical exam indicated cerclage. In twins, again, we're doing the randomized study, so it's not standard, but there's some data that ultrasound indicated cerclage if the cervix is less than 15 seems to be the best cutoff in twins, may be considered. And if the cervix is open, a randomized studies has shown that the pregnancy can be prolonged more than 5 weeks. Thanks, Kipro. It's a great honor to share this data with you guys today. Thanks.
Very much, Vincenzo. Perhaps you could leave your last slide, because that's a nice summary and it will be the basis of discussion. Can you bring back your last slide?
Yes. I'll bring it back. Let me do it again. I'll do it from the beginning. Go ahead.
Okay.
You talk. I'll bring it back. Can you see it?
Yes, the last.
I'll bring the last slide. Yeah.
Okay. So you have various. It's good that you have moved your original concept that the circulation in twins is almost contraindicated. You convinced me for a few decades, but now you're providing evidence that that may not be the case. How long will it take you to complete the trial, Vincenzo? That's another problem with trials, isn't it?
So I showed you. So, you know, we talked about meta-analysis. We're about trials. You've done trials. Roberto's done trials. I've done many trials. Trials are important. We're doing a randomized studies on singleton. This is going better. We only need 200 something, and we have randomized maybe 100 some. In twins, it's going very slow. It will take us many years if we go at this rate. But we're doing both, and if people want to collaborate, I just don't know how other people randomizing, and it's important. You know, we're not going to make progress. We made a lot of progress. We have a lot of randomized trial data, but we need more. We don't have enough yet.
Yeah, I think that let me move on to a few parallel things. Progesterone again in twins, and the Arabin pessary in twins. We haven't touched that, and what is the role of that in both singletons and twins. Let's deal with progesterone. Vincenzo, what is your view on progesterone?
So my view on progesterone is that it should not be given to every singleton or twins. I agree with Roberto. I think that if you have a prior spontaneous sperm birth, there is so much data that it's confusing. ACOG and SMFM still recommend progesterone for prior spontaneous sperm birth. We actually it's a third randomized study we're doing. We're actually comparing right now vaginal progesterone for a prior spontaneous sperm birth to 17P, because as Roberto said, it's very still controversial here. We actually have finished the randomized study. We're going to submit the data. I don't know it yet. We haven't analyzed it completely, but we will submit an abstract to SMFM. And if you want, Philomelic Foundation and anything else, I'm very curious to know. But we do. So what we do, we have randomized till recently. I think that the data is pending. The vaginal progesterone is better if you're going to use a progesterone. That's how I read the literature. I think you read it probably the same way. In twins, you know, it's controversial. It's not, most societies do not recommend it, but we do screen twins with one transvaginal ultrasound. And if the cervix is less than 25, we do offer vaginal progesterone based on Roberto meta-analysis and some other data.
You want to summarize that, Roberto? Twins and progesterone?
So in twins, or if we take all twins and give them vaginal progesterone, this intervention is not effective in reducing the rate of preterm birth. If the question is whether twins with a short cervix, 25 millimeters, will benefit from progesterone, the results of our IPD meta-analysis suggest that vaginal progesterone reduces the rate of preterm birth. And if we do a sensitivity analysis excluding one of the trials, is still effective. There are ongoing trials, notably one in the United States, in which twin gestations are being randomized to no intervention, pessary, or vaginal progesterone. And this trial has been going on for a while. We have to wait for the results. So progesterone to all twins is not effective. Progesterone in women with a short cervix, our meta-analysis suggests that it reduces the rate of preterm birth and improves neonatal morbidity, and you know about the sensitivity analysis. 17-HPC should not be used in twin gestations or now even in singleton gestation for any indication.
Okay, Vincenzo, and you agree on that, Vincenzo, isn't it? Because you said that you would also give progesterone for twins with a short cervix.
Yeah, I agree on that part. I agree on the fact that we need the results of the ongoing randomized studies. On singleton, I think it's controversial. You know, 17P. I can't wait to see the results of our own randomized studies comparing 17P to vaginal progesterone. But I do agree the vaginal progesterone seems to be better. I'm just waiting for more data to confirm that.
But I want to be clear. The prolonged trial, so the trial that largely, is the basis for the use of 17-HPC to prevent recurrent preterm birth, is the trial of the Network of Maternal Fetal Medicine Units, 400 patients. The prolonged trial is 1,600 patients conducted all over the world, and there is no evidence of efficacy to prevent preterm birth at any gestational age, in any place. So I don't believe that there is any role for 17-HPC in the prevention of recurrent preterm birth. I think this issue is.
And Roberto has been very involved, but people may not know. The FDA may actually, take away the license for Makina, which is the brand name for 17P. That's still ongoing. Roberto, you may have the latest, but that's how important those prolonged data were here in the United States.
Yeah. Olivia from South Africa wants to ask a question.
Thank you very much for the excellent presentations. On the issue of amniocentesis, I tend to measure the cervix before doing an invasive procedure, whether it's a CVS or an amniocentesis. And I think that underlines the apprehension that many of us have about doing an amniocentesis on a short cervix. I wanted to know what would you quote as the risk of miscarriage when performing an invasive procedure with a short cervix? Do we still say it's 0.1%, 1%? What do the others do? Because presumably our duty is to preserve the pregnancy until we have proven there is an underlying pathological chromosomal abnormality. Thank you.
Sure.
It's interesting
Olivia.
that Roberto answered your question.
Sure.
In a sense,
Olivia,
Olivia,
I am so glad that you asked the
Yes.
question, Olivia. So, first of all, the risk of the best estimate of the risk of pregnancy loss after a mid-trimester amniocentesis is a randomized clinical trial done in Denmark, and the risk is 1%, the best estimate. Now, thank you for asking me, about what is the risk of amnio. I imagine that in the context of cervical insufficiency, it can only be higher. It cannot be even the same. It doesn't make any sense. It has to be higher. And when we make recommendations about how to manage patients with complications of pregnancy, let me remind you that the standard of care is the minimum care. So I am not advocating that everybody does amnio. This is what we do because we are interested in providing the best care for our patients. So if you want to manage patients with doing amniocentesis, I don't have any problems, and I don't feel offended if people don't want to do amniocentesis. This is perfectly fine. Everyone has to calculate and make a recommendation. So most people are managing patients with amniocentesis. We are interested in optimizing the care of patients, and we believe that we need to understand why patients are failing let's say medical treatment, vaginal progesterone, to shorten the cervix before we take them to the operating room and place a cerclage. And remember, cerclage has its own complications. There are maternal death, etc. So I am not here, advocating that everybody do amnios. I told you what we do and why. But if you prefer to manage patients without an amniocentesis, this is perfectly fine. And now, what do we tell patients? That if they have, let me make a distinction. The patient who has cervical insufficiency, there is no cervix, the membranes are prolapsed into the vagina. We tell our patients that they have a chance 1 in 2 of having infection, and if they have infection or inflammation, the treatment is intravenous antibiotics for an extended period of time, and that the only way to know if there is an infection or inflammation and to monitor this is with an amnio. Perhaps a few years from now, we'll have a non-invasive step, but we don't have that now. Now, can you manage the patients without the amnio? Of course, yes. This is how it's done in most of the world. So, Olivia, I think I have answered the question. In sort of uncomplicated mid-trimester amniocentesis, the rate of loss is 1%. It has to be higher in patients who have acute cervical insufficiency. I don't know what it is. The chance that a patient will have an intramniotic infection is 1 in 2 if the patient presents with cervical insufficiency. only 9% if the patients have a short cervix. And I think that you should use that information to counsel patients and then, of course, to design optimal therapy for your patients who are your responsibility.
So thank you very much, Professor Romero. So if we are about to do an amniocentesis for a patient with a high risk of Down syndrome, and we find that the cervix is 18 millimeters, what should we tell her about her risk of miscarriage? Should we institute some preventative measure and postpone the amniocentesis? Is there any data for us to tell the patient your risk has increased by X, we should postpone? I think that's where my apprehension lies.
Sure. So I want to be, the risk of amniocentesis, the randomized clinical trial from Denmark and table that I just described, that did not have information about cervical length. So this is the overall risk, and there is no information about whether the risk increases or not if the patient has a short cervix. I believe that it would increase, but this is my opinion, not based on empirical evidence.
You did, Roberto.
Chime in.
The shorter the cervix, the greater is the risk that there is amniotic infection already.
Yes.
So by definition, there would be an increase. But Vincenzo, you wanted to comment. Yeah.
Yeah, I think, as a clinician, I face this all the time. And I think the counseling to the woman is extremely important. You first should start with a baseline risk. And clearly somebody with an 18 millimeters cervical length, let's say at 18 weeks or whenever you're doing the amnio, it's higher than somebody else with a normal cervix. So the counseling gets important. I will never forget, 30 years ago, I was watching another fellow. She did an amniocentesis, somebody was 1 centimeter dilated. She put the needle in, she ruptured. Okay, put the needle in, she ruptured. Was it the amnio? I don't know. The lady was probably inflamed, as Roberto said. High chance there was infection ready. High chance without amniocentesis, she would have ruptured anyway. So I beg you to counsel her beforehand. And there are tables. You can follow tables that have been published in AJOG and in many other journals. Follow table, you put gestational age, you put cervical length, you put how open the cervix is. Your risk of delivering preterm in the next week or month or 37 weeks is 10%, 20%, 40%. That's where you start. And then over that, yes, the amniocentesis may increase it a little bit. But if your risk is already 20%, Roberto's making the case, if you increase the risk a little bit, but you get information that saves your life, because by putting a circulation may make things worse, that's when it's worth it. But the baseline, to me, it's extremely important in the counseling.
Kipros, may I say, I believe that, what has happened is this is a very important subject. It affects our life because it's very common, but we are trying to compress a very complex issue in a very short period of time. And I think we have tried our best, but I constrain the conversation to cervical insufficiency. Perhaps, we can discuss at another time and give the appropriate time to make the different arguments.
We will. Lawrence Platt. Larry?
Thank you very much, Kipros, and thank you, Roberto and Vince, for 2 great lectures. I have 2 simple questions. One is to Vince. Are you using the same antibiotics that Roberto has suggested, or are you using something different? And the second question will be to both of you, but particularly Roberto, because you did articulate the FDA issue for the US and the 17-OHP and the prolonged trial. Are we crazy for still offering it for this, quote, shared decision-making process that we've been suggested? Why are our societies so unwilling to come out and say it doesn't work?
So I'll take quickly the antibiotics one. I'll leave the FDA to Roberto. So smart, huh? The Emily Miller from Northwestern published nice randomized studies on cerclage. She randomized indomethacin and antibiotics or no indomethacin antibiotics and found a benefit. And that's the best level 1 evidence that antibiotics and indomethacin work when you do a cerclage. She used most of the time Ancef, 1 dose before the cerclage, and that's what we use. I think that the evidence is not final. I think what Roberto is saying is extremely interesting. I think, most of the time I'm a clinician, and so when I do cerclage, if the cervix is short or open, I think that there's good evidence that at least one dose of ANSEF helps. I think different, more antibiotics. Roberto makes a great case for macrolide, and I completely agree with him. Maybe ANSEF and the macrolide, will be helpful. And we need more randomized studies. And since there are 4,000 people here, hopefully it won't be left just the 2 or 3 of us to continue to do this research. Roberto?
So there are 2 issues: antibiotics. The choice, the antibiotic choices that we use are informed by the microbiology. And I want to separate the issues of prophylactic administration of antibiotics before cerclage and the treatment of intraamniotic infection. These are 2 completely different problems. In general, prophylactic antibiotics work in surgery, and it doesn't really matter what antibiotics one uses to reduce the rate of infection. So if the goal of antibiotic administration is to reduce infection-related complications with a surgical procedure, be that hysterectomy, be that a cesarean delivery or cerclage, probably it doesn't matter what antibiotics we use. If the question is to treat intraamniotic infection, the most common organism are genital mycoplasmas, and antibiotics or cephalosporins do nothing for it. And because these infections are polymicrobial, this is the reason why we have used this combination, and we have proven that it's effective to eradicate intraamniotic infection, and there are no other studies that have shown that. So that is the rationale for the antibiotics. In terms of the recommendations of 17-OHPC, I think that the evidence is so clear. When you have a trial that is 1,600 patients and is negative, there is no justification for continuing to use this medication. And I don't want to second guess the motivations of professional organizations in the US as to make these recommendations. I think I want to be prudent about doing it. But the only thing I want to say is that the FDA regulates the marketing of drugs, not the practice of medicine. Remember that we use antibiotics, we use magnesium sulfate, and this is not approved by and glucocorticoids. None of these interventions are approved by the FDA. The FDA regulates the marketing of drugs, not the practice of medicine, and we should not rely on the FDA. Now, if the FDA will suspend or not the use of 17-OHPC, that's for drug companies. But we as physicians have an obligation not to give a medication that has no evidence of efficacy, regardless of what other people say.
But the fact is, Roberto, if the indication is not there, it's a very, very different decision for clinicians who are forced to do something in a shared decision and speak to the patient. And I think that, all of us have to have a greater voice in influencing those societies that are pushing us in the unscientific way effectively.
First, let me, I've been president of SMFM and part of ACOG, boards, etc. I don't think so, from the inside, I don't think so. I think in the case of 17P, again, this is my personal opinion, the first ever positive trial of the network, which receives, millions and millions, tens of millions of dollars from the NIH every year, was on 17P. And it was the first positive trial ever. Again, it was 2003, it was years ago, but I think there are still many people involved in the trial in positions at ACOG at SMFM who rely on the data, despite the fact that a lot of other data. Again, I'm Italian as well, you're Greek, we know about corruptions. I haven't seen any corruption at SMFM at ACOG, but I've seen a belief, fortunately or unfortunately, in NIH data, despite the fact that there's a lot of other data as well that we should consider.
So, Vincenzo, this is Capers. I believe that we need, if there is interest, we can discuss this at another time. But I'd like to remind you that there was an anomaly in the first NIH trial, that the rate of preterm delivery in the placebo group was 54%. That was an anomaly. And that is the reason why the FDA, at the beginning, the advisory committee did not recommend approval of 17-OHPC. and there was only interim approval pending a second trial. When the second trial was conducted, the results of the prolonged trial are clear. And why professional organizations continue to recommend offering this option is, to me, is a mystery, and I would recommend reading the paper by David Nelson from Southwestern Medical School in Dallas, published in the American Journal, because this issue of what are the motivations for this recommendation is at the very least, is I believe is a very pertinent question.
Vincenzo, let's move on before I make more provocative statements. Two questions in relation to cervical cerclage. When do you remove the stitch? At what gestation?
We remove it at 36 weeks,
36
routinely.
weeks.
The data is that 95% of the time you can do it in the office, actually. It's not that painful. 5% of the time, you need maybe to give some more anesthesia, regional, et cetera. But 95%, we remove it at 36 weeks in the office.
And the second question, again, in relation to removal of cerclage, would you remove a cerclage if you have ruptured membranes in the absence of clinical evidence of infection?
So that's very controversial. There's only one small trial I know of from the US, lots of retrospective data, some of it we published. We do in general, the incidence of it. I think the counseling at that point goes, if we keep the cerclage, you may gain a little bit more that time, and that's proven. But if you keep the cerclage, you also may have a higher risk of infection. And since with PPROM, and Roberta's taught us this well, the incidence of infection is so high already, if you keep a cerclage, it's even higher. Then we all have seen women who get extremely sick from infection, so we'll remove the cerclage. There have been some patients, 23, 24, 25, 26 weeks, who really want to gain another 2, 3, 4 days to get the steroids on, etc. That's the most that we will allow. Again, it's battery, to take it out if they decline, but our recommendation is to take it out, especially if she ruptured after 28 weeks and she's gotten steroids, because then the risk of infection, I don't think, pays compared to the small prolongation.
Alfred?
Thank you. An important question that we see clinically: what is the upper gestational age limit for placing a cerclage that's exam indicated? 24 weeks? Do you go beyond? There's some push down now because of the viability change. What's your thoughts?
So my thoughts clinically, Alfred, and I know you do clinical work most of the time, like many of us, is 23 weeks and 6 days. And that's solely based on the evidence. Most randomized studies, not all of them, go to 23 and 6/7. There are data after 24 and 0. They show also some benefit in some population. I will be, careful. And I think the message needs to be, for clinicians first, but also researchers, that area needs more research. Yeah.
So I believe that the idea of limiting cerclage to 24 weeks of gestation is something that has been done in practice because there is the fear of the complications, essentially rupture membranes after the placement of a cerclage. So there is a preference for not placing a cerclage beyond that because, that's a viable pregnancy. So, but the evidence, there is no evidence to say that cerclage are not effective after 24 weeks. And actually there is evidence that shows that they're effective. So I think that we need to keep an open mind. Uncontrolled trials in the US, Miles Noble published in the American Journal 2 decades ago, to show that cerclages can be placed all the way to 27 weeks. And there is also the work from the Netherlands, and the results are consistent. So the idea that we have to limit this procedure to 24 weeks is in the minds of some people. There is no scientific evidence to support that.